Hi there, I am Jhalak Gupta, Physiotherapist. You must have read my introduction in the first page of my webinar. So in this video, I'm going to tell you the treatment plans which has been accepted by various researchers and which has proved beneficial for the wrist pain. So this video is based on the evidences. Now, I'm not going to focus on the individual wrist conditions which causes the wrist pain, such as the carpal tunnel syndrome or double crush syndrome, decoherence disease, or in case of minor wrist injuries or wrist sprains. Instead, I will be focusing on the treatment plan which is overall helpful in the wrist pain, whatever be the pathological condition is. So let's start. One of the study, it says that if you have the wrist pain, better is that you just don't work on the wrist, you work on the forearm muscles also. So wherever we feel the pain, say for example, if the patient is having a tender point in the forearm muscle, right? So the best thing is that we palpate that tender point where the patient is having the maximum pain and remove the slack forearm of finger, and then apply a ischemic compression on the tender point and apply the transverse and the vertical direction MFR, myofascial release therapy. But before applying that, because as we all know as professionals, so the blood supply to the wrist joint is minimum, right? It's not a fully supplied joint, so it takes time for the wrist joint to heal up. And we must have noticed in many of the cases who are the wrist joint pain patients, that after we have treated them, after some time they again come up to us and say that, oh, I'm feeling the pain again, once again in my wrist. And the reason is because the patient sometimes ignore the symptoms, or the patient comes late to us. So better is that we treat the wrist pain as soon as possible, so that the blood supply heal it properly in the early stages. Now, how we can increase the blood supply while we are treating it is that researchers say that it's better that when you're treating the wrist joint and we're focusing on the forearm muscles, whichever area we are treating, we should rub that area with our hand. So once we are rubbing that area with our hand, we are creating the kinetic energy, and thus in turn we are stimulating the blood flow to that area. Then dig in the finger. When we are applying the MFR technique, just dig in the finger, apply the transverse or the vertical friction massage on that area, right? And then apply ischemic compression. Now what does ischemic compression do is that the ischemic compression basically it creates the muscle spasm on that area, and in turn it deactivates the C fibers which carry the pain sensation to the brain, right? And the second technique is that when we are applying the MFR, we can also simultaneously ask the patient to make a tight fist like this and straighten the finger joints. When they are straightening the finger joint, in turn they are juicing the finger joints, right? And we are activating the connective tissue and thus making the connective tissue stronger. So the exercises and the MFR should be done along with the movement. So researchers focus on that whichever technique we are applying, it's important that we do it along with the movement. Every technique should be done with the movement. This will give the positive and the best results for the wrist pain, right? Also, there is the stimulation of the stretch reflex in the wrist joint, right, in the hypotonic muscles. As we all know as professionals that whenever there is pain in any of the joint, right, whether being a wrist joint or whether being the knee joint, whichever, it creates weakness. So there is muscle hypotonia. So we create a stretch reflex on the hypotonic muscle, and in turn it strengthens the muscles. Now there has been 4 stages of the myofascial release therapy which has been described by Mock. He says that if you follow the 4 stages of the myofascial release therapy, that means you're working in the right direction, because you're progressing from stage 1 to stage 4, right? So the first stage of the myofascial release therapy is that we are not working in the tensed muscle, right? Our criteria of treatment should be that in case of MFR, that the patient develops confidence in us. The patient not feel that, oh, what we are doing with him or her, right? So first, let the soft tissues around the pain get relaxed. So we will work in the non-tension area, right? That's the pain-free area. Then once the non-tension area is relieved, phase 2 comes, that when we are working on the tensed muscle. So when we are working on the tensed muscle, it is important to note that we are working on the tensed muscle and the muscle is getting relieved, right? When we are working in the muscle from distal to proximal, the tensed muscle, they are somewhat getting relieved. And the third stage is that we are passively stretching along with the MFR technique. When we are passively stretching along with the MFR technique, the fourth stage comes when we ask the patient to do the movements actively, right? And we in turn apply the resistance. So the fourth stage is actually divided into two parts. The first part is that patient is doing the movement actively, and the second part is that we are applying resistance to the active movement which is being done by the patient. Right, now the researchers, they say that the 45-degree angle into both the tissue and the treatment direction will actually ensure that the desired stretch reflex has been done by the MFR, and supplementary 45-degree angle in the fiber direction may also be required. There's another study which says that the MFR actually is, once we find the sore trigger point and we apply the ischemic compression to that area and we fully stretch the muscle, we can also do the rollout technique. So for example, if we are using a ball or any kind of tennis ball or a cricket ball, we can roll onto the trigger point area, and wherever patient is feeling pain sensitive to that area, sensitive to that point, we can apply pressure into that area, giving a ischemic compression. So main funda which comes into play is that whether it is MFR technique, we have to do the movement along with technique and ask the patient to actively do the movement along with the pressure ischemic compression that you are doing, because you are deactivating the C fibers and thus enhancing the movement. So this will give the positive results. Then it has been shown that the MFR, it increases the AP and the transverse carpal tunnel diameter, right? So once it increases the carpal tunnel diameter, obviously it will release the nerve pressure. There are two types of MFR described by the researchers. One is the direct myofascial release therapy, one is the indirect. In direct myofascial release therapy, we work on the restriction barrier and instantly apply the constant sustained pressure onto the involved part until the tissue relaxes, right? And in the indirect MFR, we are working against the restriction barrier. We are not focusing on the restriction barrier, we are not focusing on the dysfunctioning of the tissues, right? We are working against that direction, so that, and then we apply the resistance, and then we follow all the four stages described by the Mock, slowly and gradually, right? But before applying MFR, it is very important to remember for all of us that we increase the blood supply by rubbing that area. This has been said by many researchers before starting the treatment with the wrist joint. MFR, it causes relaxation. In turn, it is accompanied by the sensation of muscle spasm. Right, now there is if there is a carpal tunnel syndrome, say for example, there's a technique which is GISTM. GISTM stands for the Graston Instrument Assisted Soft Tissue Mobilization. Now this technique is beneficial for the therapist. Why? Because the therapist hand don't get tired, because whenever you're applying MFR, we are using the knuckles or the elbow, or sometimes we are using our thumbs or fingers, depend upon the area and depend upon our positioning while we are treating the patients. So the GISTM technique, it says that it has the instruments, right, for our fascia release. So we can use that instrument, and GISTM, it works in such a way that it does not involve the median nerve, right? So it significantly increases the myofascia of the forearm, wrist and hand. Release the myofascia of the forearm, wrist and hand. It is actually a manipulative therapy for the myofascia, whereas the soft tissue mobilization, we can say that it is a mobilization technique for the fascia. Now we can also say that say for example, if there's a decurrence disease, and there is an inflammation of the tendon, synovial sheath of the extensor pollicis brevis and the adductor pollicis longus, one of the scientists, the Braxton, he says that we can also do the MWM, that is mobilization with movement, is the best for treating the wrist pain, right? And the mobilization, basically he says that it is more than that we do the radial gliding of the proximal carpal lobe and the undergliding of the distal carpal root, trapezium capitate manipulation, the first CMC joint mobilization, and also the transverse friction to the first dorsal tunnel. And studies also says that the Australian approach is being done by the researchers, which says that there was a case study of 6-year-old female who had a cervical spine dysfunction along with the wrist joint dysfunction, and also there was the decurrent stenosynovitis plus hand numbness and tingling sensation in her hands, and the radial and the median nerve was involved. And the treatment that they followed amazingly was that they followed the cervical unilateral and the central mobilization of the cervical spine, along with it the neurodynamics technique plus the Maitland glides and the transverse friction massage to the abductor pollicis longus and the extensor pollicis brevis. After 6 months, they noticed that there was subsequent decrease in pain, and almost the patient didn't complain of pain after 6 months, because they started a treatment plan just after she started feeling pain. It also depends upon our patient, because patients sometimes avoid the pain and they come late to us, so nothing can be done in that situation. We can only try our best. But in every research it is said that whether you're applying Maitland, whether you're applying C-Reacts, whether you're applying myofascial release therapy, do everything with movement, progress to the passive to active to resistive movements, and along with it just rub that area to increase the blood supply, right? So it will give the wonderful results. Now, those who have done the chiropractic, like I have done the chiropractic technique, right? So those who have done the chiropractic, it gives the amazing results if you combine chiropractics with the manual therapy, right? Along with the manual therapy, you are doing the chiropractic technique. Now in chiropractics, we follow 6-point treatment plan. We not only work with if the patient complains of wrist pain, we not only work on the wrist joint, we will start from the neck. So we will be manipulating the joints, we will be manipulating the dysfunction of the joints and adjusting the joints, basically of the cervical spine. Also we will be treating the shoulder, the elbow, the wrist, the fingers, everything will be adjusting. So there's a 6-point treatment plan. Once everything is adjusted, because the brachial plexus, the nerve can be compressed from that area also. So we need to know the root cause where all places nerves are compressed. We cannot only directly focus on the wrist joint. So if we combine the manual therapy along with the chiropractic, it gives wonderful results. It's said by the chiropractors and the physiotherapist who have done the manual therapy. But those who have not done the chiropractics, we physiotherapists can also treat it without chiropractics, not to worry. But yes, chiropractics gives a more positive outcome if we add on to it, because we work at the bone adjustment levels. Along with it, exercises are really important, because if we do the adjustment of the patient bones, and once he or she goes home, then again he or she can return with the pain, because the muscles and ligaments are not supporting them. So it is very important that our muscles and ligaments support us during the chiropractic treatment session. Then it is said that the osteopathic manipulation, it elongates the carpal ligament and it releases the carpal tunnel syndrome. It releases the median nerve in the osteopathic manipulation in case of wrist joint. There's also been said that there are the exercises which are the tendon gliding exercises, right? The tendon gliding exercises, they decrease the symptoms by allowing nerve to move freely. They decrease the adhesions between the nerve neural sheaths, and they facilitate the venous return and edema dispersal. And thus it oxygenates the nerve and increase the blood supply, thus relieving the ischemic pain. And it has been said that it broadens the longitudinal area contact between the median nerve and the carpal tunnel, right? So there has been researches done on modalities. Now what modalities we physiotherapists can use? One of the modality that all the researchers has focused on is laser therapy, right? So low level laser therapy, LLT, has been used, and the two type of lasers were used, that is the helium neon laser, and another one was the gallium arsenide laser. And it has shown that the biological effects on the carpal tunnel syndrome, or whether the decurrence disease, as it activates the acetylcholine esterase increases the ATP formation, activates the DNA RNA synthesis, plus increase the cellular oxygen consumption and increase the endorphin production. Now from what can you make a connection that what we are getting is, thing is that wrist has less blood supply, so our aim is to include those modalities, those treatment plan, so that we can increase the, at least at treatment time, we can increase the oxygen supply to that area and we can increase the blood supply to that area for improving the healing capacity, so that healing takes place faster in the early stages rather than lingering on the later stages. So it has said that the helium neon and the gallium arsenide laser works really pretty well, and we apply it on the transverse carpal ligament by the 3-point contact area, right? And it has shown that the sensory latency, the Phelan's test, the Tennel sign, as well as the hand grip and the pinch grip strength drastically improves with the laser therapy. Laser therapy do poses negative effects such as tissue damage, but all the researchers, in fact all the researchers, it says that the laser therapy do poses negative effects, but once the laser therapy is stopped, the tissue repair itself. So the positive effects dominates the negative effect of the laser therapy, so it's safe to use the laser therapy. Also, they have used the dosage of laser therapy. They use 830 nm laser at 60 megawatt at transverse carpal ligament for 14 days, and the results turn out to be positive. And they also use the red laser, which was actually the R650 probe, and they use 658 nm and 50 megawatt for 1 minute 30 seconds almost at one treatment session for 15 days, and by the contact method, and it drastically improved the elasticity of the transverse carpal ligament, thus relieving the median nerve and thus relieving the pain from the CTS. Now, it is also said that the manual therapy, one direction proximal and distal tension mobilization can be effective. One reason it says that the median nerve and the tendon motion with the wrist flexion, it has been said that the median nerve is actually restricted with the wrist flexion, right? So we can very well understand that the longitudinal section, it is disturbed in case of CTS, but researchers are still going on with the transverse section of the wrist joint, right? So whether the transverse structures also causes the difference in pain if we treat them. But of course, the wrist flexion extension, in flexion cases, if we flex the wrist joint in case of CTS, definitely the patient will feel pain because of the compression of the median nerve. So it has been said that longitudinal part of the structures do get affected, but the transverse structures, whether they are affected or not, is still yet to be known. Also, the index finger and the thumb motion is more seen that the distance is more between the nerve and tendon in CTS than in the normal subjects. So this is all about the researchers, and the gist of this whole research theory is that whether we are applying the MFR or Midland or C-Reacts or neurodynamics and tendon gliding exercises, and if you know the chiropractics, do it along with the movement and progress by 1 to phase 4 described by Mock in case of MFR, but in case of movements we can also follow these stages of the MFR, right? So progressing from passive to active to resistance exercises, and giving the patient at home the maintenance plan to follow, which is really very important for all of us. So this gist I gathered from reading the almost 30 research articles, and what the majority of the researchers study focuses on, and what benefits, the common benefits that they have gathered. So this treatment plan we can follow on our patients. So basically the MFR, the neurodynamics, the Maitland, along with the chiropractics and also the tendon gliding exercises are beneficial for the wrist pain. So this was all about the evidence study of the wrist pain. Hope you like it, and thank you for listening me. Stay safe and see you. Bye bye.